So cancers of the pulmonary system include cancers of both the lung pleura and of the lung itself. So lung pleura would be the mesothelioma. And the lung itself we can divide histologically into small cell carcinomas and non-small cell carcinomas. So now we're going to go to focus on the mesothelioma malignancy of the lung pleura. The main risk factor here is asbestos, okay? Smoking is not a risk factor. I want to emphasize that. Smoking is not a risk factor. The main risk factor is asbestos. So, what clinical features would you expect for a patient with cancer of the lung pleura? And we already talked about a pathology that involved this. Do you remember the pathology? Remember the pathology was a pleural effusion. Okay. Remember, was it going to be a transudative or a exudative pleural effusion? Remember that we said that it's going to be an exudative pleural effusion because the tumor is going to cause increased capillary permeability. And so what were the markers that we're going to see in the exudative pleural effusion? Remember, we're going to see increased protein, increased LEH. And in this case, you're also going to see blood in that pleural effusion. It's going to be hemorrhagic because, again, as always, cancers bleed because cancers are supervascular. They're going to end up bleeding. The other thing you're going to see is this pleural thickening on the right side of this image. This is a CT scan, but you're going to see it on pleural thickening on CT scan and X-ray. So you can see here, it's very distinct, very visible that there's thickening of the pleura. In contrast, on this side, on the right lung, there's pretty much imperceptible pleura. Okay, but you get this pleural thickening from the malignancy of the lung pleura and mesothelioma. So hemorrhagic pleural effusions, pleural thickening for mesothelioma. Now we go to lung cancers. This is a malignancy originating from the airway or the lung parenchyma. Okay, mesothelioma is cancer from the lung pleura. Lung cancer is either from the airway or from the lung parenchyma. That's the tissue of the lung. Now this is going to be asymptomatic until the late stages, until it's spread out enough to be causing symptoms. And symptoms you're going to see are shortness of breath, cough, and hemoptysis. So I want to emphasize, you're going to have a patient who has this tumor in the lung, but they're going to be completely asymptomatic. So they're not going to be detected until late in the game. And because of this late detection, over 50% of patients have metastasis by the time of diagnosis. This is why lung cancer is the leading cause of cancer death worldwide. First of all, it's common, and second of all, by the time we do detect it, the prognosis isn't great because a lot of times it's already spread. Okay, that's because we have poor screening methods for this. For colon cancer, we have a great screening method. What do? We do colonoscopy. For breast cancer, what do? We have mammography. For cervical cancer, we have pap smears. Lung cancer, well, if patients who have risk factors, we can do CAT scans, but then patients who don't have risk factors, we don't screen them. So that's why you can get very late detection and poor prognosis. Now, the other thing to add is that if you see a lung tumor, more often than not, the tumor is a result of metastasis rather than a primary neoplasm. For example, metastasis from a primary breast cancer, metastasis from prostate cancer, okay? Final thing, what are the risk factors? This is very easy. Risk factors include smoking, asbestos, and family history. And I want to focus on asbestos. Remember, we talked about asbestos. What cancers does it put you at risk for? It puts you at risk for mesothelioma and bronchogenic carcinoma. So bronchogenic carcinoma from the airway, so that's a lung cancer. Remember, which one was more common? Remember that asbestos, you're more likely to get a bronchogenic carcinoma than a mesothelioma. Okay. Now we're going to look in depth at the lung cancers by the histological type. Let's look at small cell lung cancers first. These are 15% of all the lung cancers. These are aggressive, and surgery doesn't work for these patients. Even if they have a localized tumor, you need to give them chemo plus or minus radiation. Surgery doesn't work. Okay, so even if the tumor is like here, it's very nice, very localized, you think you cut out, you don't do that. You give them chemo. Localization of the tumor. Small cell is central, so it's centrally located, as you can see in my drawing. And again, this is a very aggressive type, and it often secretes hormones or hormone-like substances. And this makes a lot of sense because this tumor is of neuroendocrine origin. So obviously, if it's endocrine origin, it's going to be secreting hormones or other substances. And on histology, what you're going to see is these Kolchitsky cells. These are small dark blue cells, and these are cells of neuroendocrine origin, Kolchitsky cells. And the other thing you're going to see is you're going to stain positive for neuroendocrine markers such as neuron-specific enolase, synaptophysin, and chromogranin A. So these are all neuroendocrine markers. Kolchitsky cells are neuroendocrine cells. They're small dark blue cells. And associated with smokers. A lot of these lung cancers are associated with smokers. A few of them are associated with non-smokers. And I want to focus on the hormones again. So the hormones that small cell lung cancer secretes are the three A's: ACTH, ADH, and then the last one is antibodies. So that's more like substances rather than hormones. So ACTH, what happens if you have oversecretion of ACTH? You're going to overactivate the adrenal cortex to make cortisol, and so you're going to get too much cortisol, you're going to get Cushing's syndrome. Okay, that's from too much ACTH from a small cell lung cancer. Too much ADH, antidiuretic hormone, leads to SIADH. That's syndrome of inappropriate ADH release. And what does ADH do? Right, ADH acts on the collecting ducts of the kidneys to reabsorb water, and you're going to have too much water reabsorption. You're going to dilute your sodium, you get hyponatremia. So you get hyponatremia and SIADH. And finally, Lambert-Eaton syndrome. Remember, this is a syndrome that we saw in the MSK section. What was the very classic symptom here? Remember, the classic symptom is going to be proximal muscle weakness that improves with repetition. Okay, proximal muscle weakness that improves with repetition. I'm going to draw this out. We have the neuromuscular junction. So neuromuscular. Remember that we have calcium 2+ channels here. And normally calcium comes in and it's going to trigger ACH, acetylcholine release. Okay, acetylcholine is going to go to the muscle and trigger muscle contractions. However, in Lambert-Eaton syndrome, you have an autoantibody against these calcium channel. It blocks calcium entrance. Calcium doesn't enter, acetylcholine does not get released. You don't get muscle contraction. And the reason why, do you remember why Lambert-Eaton got better with repetition? Remember, with more repetition, eventually calcium will be able to come through, and then once the calcium is in, then the rest of the neuromuscular junction can work, and you get acetylcholine release, you get muscle movement. Okay, so again, small cell lung cancer, very key thing is its neuroendocrine origin. That tells you a lot. It tells you Kolchitsky cells, it tells you the neuroendocrine markers, and it's going to tell you these three hormone syndromes: ACTH, ADH, autoantibodies to the calcium channels. So now we're going to go to the non-small cell cancers. So this is 85% of the lung cancers. Now these, if localized, you can treat with cancer, okay? You can treat with surgery. That's in contrast to the small cell cancers where you can't. First of all, there's three of them that we're going to talk about. First one is squamous cell carcinoma, and squamous cell is also central, okay? And squamous cell carcinoma is associated with hypercalcemia because it's going to be releasing too much PTH-related peptide. PTH-related peptide leads to hypercalcemia. And the other thing you want to know is you want to be able to identify these keratin pearls and intercellular bridges on histology. So keratin pearl, this arrow is wrong. Keratin pearl associated with squamous cell carcinomas. This one also associated with smokers. Okay. Next is adenocarcinoma. And I want to point out these top two are centrally located, associated with smokers. Both start with S. Excuse me, let's keep that. Let's come back. So I talked about the first two, we see a pattern here. The bottom two, we're also going to see a pattern. These are going to be the peripherally located tumors. So this is your lung, and the tumors are going to be in the periphery of the lung. Okay, this is adenocarcinoma. This is the most common primary lung cancer overall. And also, it's going to be the most likely cancer in a non-smoker. Okay, you have a non-smoker who has cancer, it's most likely going to be adenocarcinoma. And you see this more commonly in women than men. Next, you see a hypertrophic osteoarthropathy, that's clubbing in the fingers, that's seen with adenocarcinoma. And this adenocarcinoma is associated with these mutations, EGFR, ALK, and KRAS, and that puts them more at risk for having an adenocarcinoma. Now, you can also have an adenocarcinoma in situ. Another name for that is a bronchoalveolar carcinoma, and that tells you a lot. Remember when you have a carcinoma in situ, that means it's non-invasive. Okay, so this is a non-invasive subtype, and it has dysplastic columnar cells that are growing along intact alveolar septae. Okay, so next is the large cell carcinomas. Again, the bottom two tumors in my chart are peripheral. So large cell carcinomas are peripheral. These are undifferentiated and anaplastic, so that means they're going to have poor prognosis. Remember, the less differentiated you are, the poorer the prognosis. The other thing you're going to see is you're going to see giant cells in histology. You know from the name already tells you that large cells, giant cells, and histology. So know all these different subtypes of lung cancer. You got the small cell, you got the chart's going to help you a lot because you got the two S's on top. They're both central, they're both associated with smoking. Small cell lung cancer has this neuroendocrine origin, so it has all these endocrine syndromes, and then the rest is pretty easy. Now we're going to go into complications. First complication is a Pancoast tumor. This is when you have a lung tumor at the apex of the lung. And the problem is with this, it's going to cause a Pancoast syndrome by compressing surrounding structures. And we're going to take a look here. Well, this is the tumor at the apex of the lung imaging. But we're going to see the surrounding structures here. So this is our tumor, this gray here. And you see surrounding structures. You have the brachial plexus, you have the cervical sympathetic ganglion, and you also have the spinal cord. These are all in the same area as this this apical tumor of the lung. So if you have compression of this brachial plexus, you can get shoulder pain that radiates toward the axilla and the scapula. And then if you could compress the cervical sympathetic ganglion, what's going to happen? Remember what happens when you compress the cervical nerves? Remember what syndrome do you get? Remember the syndrome is Horner syndrome due to compression of the cervical sympathetic ganglion. What's the presentation of Horner syndrome? Remember the mnemonic is horny PAM. Remember what does PAM stand for? PAM is ptosis, drooping of the eyelids, anhidrosis, that's lack of sweat, and meiosis, that's the constriction of the pupil. Again, all that is due to blockage, loss of the sympathetic innervation due to this compression. And finally, compression of the spinal cord can lead to paraplegia. So again, compression of brachial plexus, cervical sympathetic ganglia, and the spinal cord can all be complications of a Pancoast tumor. That's just a lung tumor at the apex of the lung. Finally, we have a superior vena cava syndrome. As you can tell from the name, it's due to obstruction of the superior vena cava. So you're going to be obstructing blood flow from the head and the upper extremity. So this is our tumor here. This is the vena cava. Completely obstructed, as you see in this picture. Not completely, but almost completely. And you see all these veins that are draining into the vena cava here are super dilated because they're not draining very well. So all that blood is backed up. And so you're going to see a variety of symptoms. You're going to see swelling and edema of the involved areas. Involved areas include the arms and the neck and the head. So swelling and edema of the arms, neck, and the head. And you're also going to see these super dilated veins, engorged veins in the upper torso. Okay, and this is characteristic of a superior vena cava syndrome. That's because you have a lung tumor that's compressing the superior vena cava. So that's it. That's it for our overview of the tumors of the pleura. That's the mesothelioma, and lung tumors. Remember that we divide them histologically, and then we overview the lung cancer complications, including compression of the superior vena cava, leading to all this dilation and edema. And then you can also have the Pancoast tumor from blockage of the brachial plexus, cervical sympathetic ganglion, and the spinal cord. So that's it for lung cancer.